Welcome back to the conditions of periodontal disease, and we left off talking about the causes of early periodontics. We talked about the inflammatory process, the chronic inflammation, pocket formation, untreated gingivitis, and then plaque and new calculus formation as well. So characteristics then is the, as a review again, the lower epithelial attachment, a deeper pocket, bone loss visible on radiographs, gingival inflammation can be there or not, can be generalized or localized, and locations of lesions may be different in sites and in sizes. So treatment for early periodontitis is plaque control, to remove the plaque, to remove the calculus, and to educate the patient on keeping it from becoming an issue again. To do a little diet information and how different things as far as sugary, sticky foods may contribute to the plaque formation by feeding the bacteria that's living in the oral cavity. And then we do have to do some pretty intricate work of removing the calculus, starting some root planing, maybe a gingivectomy at this point. That might be a little bit of an overkill when pockets are 4 millimeters, but if they jump up to 6, that may be something to consider. Correction of restorative areas, if those are contributing to the problem as far as overhangs or open margins. We can begin antimicrobial therapy, which will be rinses, packing of antimicrobial medications, gels, and discs. We can do occlusal therapy if that is something that is contributing to the loss of attachment, minor orthodontic movement, to correct crowding, or provisional splinting is something we'll talk about later to correct these issues. So early periodontitis looks a lot like this. We have the inflammation of the tissue, the soft tissue, and then we have the radiographic visibility of the loss of the bone structure. So in this case, radiographs do show a generalized horizontal bone loss that varies in severity in the different areas throughout the oral cavity. So here's our upper right, and there's definitely some bone loss here. Bone loss on the upper left as well. Bone loss is not as severe on the mandibular aspect of the oral cavity. Looks like in the anterior there's even more bone loss that's happened. Case type 3 of moderate periodontitis. This is a more advanced stage of early periodontitis. We have an increased destruction of the periodontal structures, which is following that apical path. The periodontal pockets are deeper at this point. They're between 5 and 6 millimeters. Teeth do become mobile at this stage because we have more of the tooth outside of the supporting structures than what is resting inside of it and is stable. Bifurcation of multi-rooted teeth may be evident at this point as well. So we have the levels of the gingival attachment. Normal stages is around here, stage 2, and then now we're at the stage 3. To treat moderate periodontitis, again, plaque control, diet control, many of these are the same, just in a more aggressive format. So we're correcting the restorative areas once we remove calculus, do some root planing and gingivectomy. Again, antimicrobial therapies, occlusal therapies to remove any interferences that may happen, minor orthodontic movement once again, and splinting of the teeth to keep them from moving too dramatically. Case type 4 is advanced periodontitis. This is where half or more of the original bone holding the tooth has been lost to the disease. Pockets in this case are usually 7 millimeters or greater. The margin of the gum may withdraw down the root towards the apex even further, and gum recession is going to expose more of the tooth, which makes the tooth appear longer. So in this case, our probe is inserted, and the top of the sulcus is at 8.5 millimeters, which is really severe, very, very difficult for the patient to clean on their own. Causes of advanced periodontitis, that inflammatory process that proceeds apically and involves the alveolar bone and supporting structures. There is chronic inflammation of the gingiva, pocket formation, untreated gingivitis, plaque and calculus accumulations, probably pus, and also blood in the sulcus upon probing. And these are your patients who haven't been to the dental office in several years to decades would present possibly with advanced periodontitis. Treatment, again, a lot of the same actors: plaque control, diet control, removing the plaque and the calculus, root planing gingivectomies, correction of the restoratives that are needing to be fixed up, antimicrobial therapy once again, orthodontic movement, provisional splinting, incisional periodontal surgery. At this point, we may need to do some osteoplasty that we talked about in our last lecture, and occlusal therapies also may be indicated. Advanced periodontitis, this graphic is going to dramatically show how much bone loss and gum recession have taken place at stage 4. So here we have a healthy alveolar process, healthy, well-adapted soft tissue, all the way up to the crown of the tooth. When we go to this part of the slide, we have our bone. It is irregular. It is very diseased. We have puffy. We have inflamed and necrotic soft tissue that is rolled and not very well adapted to the side of the tooth. The tooth is in a very terrible state at the right side of that slide. So clinical features of advanced periodontitis: we have a rapidly progressive periodontitis, and this is a 30-year-old patient. Notice the diastema between the teeth, which also allows that lower mandibular incisor to super erupt out of the socket. There's generalized discoloration and smooth, non-stippled surfaces of the tissue around here. On the lower lingual, we have some calculus formations and definitely some recession going on here, recession of the soft tissue here as well. Teeth do definitely appear longer. Here is the radiograph of that same patient, and you can see if we take the cursor and move it, this is where the level of the bone is. These maxillary incisors are barely in the bone at all at this point. The upper left molar, the bone starts way back here, dives apically, and there's definitely a furcation involvement there. Same with on the right side. These are the vertical right wing radiographs again, and we have generalized bone loss again on the bottom. The lower incisors are barely in the bone, and I would imagine they are on a high stage of mobility. Here's a panoramic x-ray of another patient with generalized bone loss, very severe bone loss. This molar is barely in the bone at all. I'm certain very mobile and not very comfortable to chew with this set of teeth. Another tooth hardly in the bone, very, very, very generalized severe bone loss here. Another type of periodontitis is case type 5. This is refractory periodontitis. This is a continued progression of the periodontal disease after treatment has been completed. So there are reasons that are unknown why these cases do not respond to treatment, and for these types of patients who have the refractory periodontitis, they can lose a tooth or a lot or all of their teeth in this progression of the disease. So results of untreated periodontitis, they can be too late for treatment. If the level of the bone has sunk to an area like this where there's literally no bone holding the tooth, it's a soft tissue attachment only, that tooth is not going to be able to be saved because there's not enough bone remaining to salvage the tooth. Inflammation surrounds the entire end of the root. The tooth is incredibly loose, If it's not extracted, the tooth will eventually fall out on its own. And it's rather pain-free for the patient. And sometimes they'll say, oh, thank God I lost that tooth because it was so loose and it gets kind of mixed up when they're chewing, and it's just a very painful, uncomfortable situation. Other pathology associated with periodontal disease is gingival enlargement, desquamative gingivitis, atrophy, prepubertal or juvenile periodontitis. Another one is acute necrotizing ulcerative gingivitis, occlusal trauma, and periodontosis. So gingival enlargement may result from chronic or acute inflammatory changes. And if you think of the name, it's exactly that. The gingival tissues just become larger than what's necessary due to some of these idiopathic causes. Can be caused by prolonged exposure to dental plaque. It's often seen in patients who breathe out of their mouth, and it can appear as a slight ballooning of the interdental papilla, just as we see in this picture. Here is a more severe case of gingival enlargement, which progresses slowly and painlessly unless it is complicated by acute infection or some kind of trauma. This enlargement may be caused by a drug-induced medication such as immunosuppressive agents and also anticonvulsants. Patients that have seizures take anticonvulsants, and this is one of the major signs that they're on that medication. This is a picture of a 21-year-old male where in the maxilla the bulbous papillary enlargements, which leave a trough between the enlarged papilla and then the rest of the attached tissue on the oral cavity. Desquamative gingivitis is another type of condition involved with periodontitis. This encompasses a variety of oral mucosal membrane diseases. It's characterized, though, by intense redness in areas where the epithelium has been lost and the underlying tissue is raw and infected by bacteria. Its cause is not specific, but usually is a manifestation of a variety of diseases, usually nutritional and hormonal disturbances. So they're not getting enough vitamins, they're not getting enough nutrition from fruits, vegetables, and that sort of thing. May vary in severity, and it's usually common in childbearing and postmenopausal women. So females are affected by this more frequently than males, and it is an extremely painful condition that once the hormones and the nutritional things are kind of taken care of, it usually is taken care of. Atrophy or recession is another gingival condition. This is where the gingival tissues recede apically and it exposes the root. This can be caused by faulty toothbrushing, so brushing too hard, using a toothbrush that is too firm, tooth alignment. So if we have the tooth having an occlusal interference, it can push that tooth and cause it to kind of bend a little bit, causing that to be moved out of the way and recede. Frenum attachments can also do this. Calculus buildups can cause recession, and as the person uses their teeth and ages, the recession also happens. Here are a couple pictures of some atrophy or recession. We have a localized area here on the cuspid and also here on the first molar, but not a lot of recession is happening elsewhere. This person is in ortho, and as the tooth is moved facially, the bone is lost because the tooth is moved towards the facial plate. Here's another little look at recession on this patient.